Hi guys, thanks for joining us today. So we're going to talk about surgery FAQ. This is Kathy Huang. I'm just going to let everyone introduce themselves. Martera, you want to go next?
Yes. Hi, everyone. I am a past surgical patient. My name is Martera Walker, and my preferred pronouns are she, her, hers. Welcome.
Okay, don't all jump in, guys.
All right, I'll go next. I'm Victoria Van Thunen. I'm a family nurse practitioner, and I am supporting the Endometriosis Center.
Kelsey.
Hi, I'm Kelsey Kossel. I'm a minimally invasive GYN surgery fellow. Or do a check in here.
Fellow. She is not a fellow.
Do you want me a second? Minimally invasive. I just finished invasive GYN surgery fellowship. I'm excited to join the NYU team here to help treat endometriosis.
Yeah, so we have to say welcome Kelsey and welcome Victoria. And Chris has been with us for a while, so.
Hi, I'm Dr. Eswar. I'm one of the other surgeons for the Endometriosis Center here at NYU. I've been here for about 4 years and I've been treating lots of patients here.
So we're gonna let Martera tell her story, but the other thing is just that if for those of you who have joined us previously, I will be monitoring the Q&A, so feel free to type your questions in the chat, and then we will please interrupt us during this process if you have any questions or clarifying questions so that we can answer all of your questions, okay? And Joy's here. Okay, so I'm gonna hand it to you, Martera.
Well, hi, everyone. Good evening. I hope you all had a great day so far. And thank you so much for joining us on this super important panel. So my story is I was first diagnosed with endometriosis back in 2011. And I had a surgery that it was supposed to be laparoscopic. However, I had a bit of complications with it. So I had I'm not sure what the medical term is, but like a cesarean cut, where they removed the endometriosis, and the size of the cysts that I had were originally supposed to be the size of softballs, but they actually were the size of grapefruits. And so I ended up in the hospital for 2.5 days, and I was on oxygen and I had a blood transfusion. So you can just imagine how I felt when I had pain and issues happening again this year. And I went first with my primary OB-GYN, who is Dr. Whitehead at Downtown Women's, who I had a very long conversation with, and she recommended Dr. Huang. She told me that Dr. Huang was amazing. This is her field. She knows what she's doing, and she's the expert, so that I need to, work with her. And so I said, okay, I'll figure it out. I did a little Google searching, and I said, you know what, Dr. Whitehead, can you tell me a little bit more about Dr. Huang? I'm just really nervous. And she, again, reiterated how Dr. Huang is an expert in her field, especially since I, had a lot of pain, probably worse than the pain that I had when I was originally diagnosed with endometriosis those years ago. So although I have a lot of confidence in my primary OB-GYN, I was still very nervous about it. So anyway, Dr. Whitehead set up a call with Dr. Huang. And I can tell you, I was super nervous, but Dr. Huang, she is so easy to talk to. She has a great personality, which makes it even easier to talk with her. And, we just did a pre-screening over the phone, and we scheduled an appointment to go in to meet face-to-face. And she said to me, Martera, any questions that you have, I'll be able to answer them for you. And I said, okay, I'm ready, because after just a little bit of the information that she had gotten from my OB-GYN with the ultrasound that they had did, it was determined before that phone call that I would definitely have to have surgery. So I went in to talk to Dr. Huang. And again, I was super nervous because it was my second time really interacting with her, and just thinking about how my surgery went before, I wasn't as confident in knowing that my surgery, I would not have any issues with my surgery. So Dr. Wong said, write down all your questions, bring them in, and I'll answer all of them. So I wrote down all the questions I had, questions regarding pain, questions regarding how long the surgery would be, questions about like what is robotic laparoscopic surgery anyway? I had no idea what that was, and that sounds really scary. And also, you know, throughout the surgery, will it help with me being able to have kids, you know, talking about fertility and all of those things. And she was able to answer all of the questions that I had, which made me feel more comfortable. And then one thing that she said that made me feel like even more confident about the surgery and more comfortable is she was like, Martera, don't worry about anything. I got you. This is what I do. You don't have to worry about anything. You're in good hands. So as soon as she said, you know what, Martera, I got you, I was like, okay, Martera, calm down and it'll be fine. And she also has webinars. So it was nice to attend the webinars even before I had my surgery so that I can see that there are other women that have the same experiences that I have, and knowing that I'm not alone in this journey, this endometriosis journey, and this journey to like fertility and all the questions that I have regarding my fertility because of the endometriosis and pain management. It was just so helpful to have these other panels and webinars. And so during this whole journey, before I had my surgery, I went to have physical therapy. Physical therapy, for me, it was okay. For some people, it may work out better. It was just okay for me. But I will tell you that even the physical therapist was very supportive and very helpful with just in conversation while I'm sitting there and I'm having all these conversations while she's doing whatever she's doing while we're in session, because it can be uncomfortable if you're not used to someone you don't know just all up in your business. And it was just nice because we were able to just talk and just the ease of knowing that I have Dr. Wong, her assistant Joanna, they are super on point with responding to emails. So it's not like you're going to send an email and you're not sure when you're going to get a response. They respond within 24 to 48 hours. So it was just great to know that building up to my surgery, I had Joanna, I had Dr. Wong, I had my physical therapist, and everybody responding to any questions that I had. And even after I had my first session in person with Dr. Wong, I had more questions that I forgot about, and she still scheduled time and made time to meet with me so that I could feel, you know, still comfortable and confident about going into the surgery. Again, like I said, just based on my background, I'm like, I'm really afraid that something could go wrong and I could be in the hospital again for 2.5 days. And she assured me that that would not be the case. I had an MRI done, I had another ultrasound done, and it prepared me for the surgery. So I'm glad that we went through all the steps possible that it would take to determine what my endometriosis was, what stage I was at, what size, all of the cysts and other things that were going on inside of my body, what that looked like, and what the surgery would be. So I would just say I am very grateful for like the post surgery support and comfort that I received. And on the day of surgery, it went very well. I can tell you that the anesthesiologist came out and he spoke to me, just had all the questions, and he was very nice. And Dr. Wong, she was wonderful. I'll tell you, when I went back and I, you know, laid on that bed and, you know, you see all the bright lights and you see this machine and you're like, oh shit, like this is really about to happen. So I'm laying there and the nurses, like everyone was there. They were so supportive and they were holding my hand and they were like, it's gonna be okay. And I mean, I don't know about everyone that's on the panel and attending, but I'm a little bit of a crier. So not like boo-boo crying, but I was crying a little bit. I had some tears coming down and they were holding my hands. And then next thing you know, I see Dr. Huang and she grabbed my hand and she was like, Martera, it's gonna be okay. She's like, you're gonna be fine. We're gonna get through this. You're gonna have a great surgery. And I was like, okay. And then next thing you know, I woke up and I was fine. I'm alive. So, so I woke up, I was in the recovery room, and the nurse that was there that was helping me, he was great, as well as the other nurse. They were wonderful with getting me back into like here into the world after being off of the anesthesia. And then Dr. Huang came and we had a little bit of a conversation. And so it was really, really nice for her to not only see me before, but during, of course, before and then post surgery. And since then, it also has been great. And one thing I did not share, I forgot that I left out, was that Dr. Huang, I'm not sure if she's sharing her background, but she, she spoke to me as someone who was also a patient and having a similar medical experience. So it was really nice to have someone on your team that understands your questions, your concerns, and your feelings about having surgery and having a surgery like the surgery that I just had. And then post, talking with Victoria, she's been great. She's been answering every single question I had. I went in, I spoke with her face to face. She's so supportive. She's so comforting. And I would just say the entire team, that I've worked with for my stage 4 endometriosis has been amazing. And if you have any questions about, will people answer your questions? Will they be supportive? Will they be comforting? Will there be recommendations? Anything to help you through this? You will have no question. Well, you will have no doubts after having a conversation with the medical team, Dr. Huang, Joanna, and Victoria, because they've just been amazing with me throughout my journey, and they're still here. I mean, my surgery was actually in August. It was August 25th. It was just a few months ago. So I can tell you that my recovery has been really good. Besides some pains that, Victoria told me I would be having because it's post and my body is still healing and in recovery. But for the most part, I am doing well in my recovery. And I'm just thankful that they've been great and supportive throughout this whole journey. So that's my story. Thanks, y'all.
Sure. That's really way too kind. But so Victoria just joined our team about Victoria, like September? I can't even remember now. Maybe
Mid-August. Yeah.
Mid-August. And then so Dr. Eswar also does what I do, and Dr. Castle also does what I do. Okay, I'm just gonna call everybody by their first name, otherwise I'm gonna get really confused. I'm gonna ask Chris first to comment on the MRI, right? So we were talking, Matera was talking about she had an ultrasound, then we did an MRI, then we did another ultrasound. And obviously the goal is to get the patient prepared so that we can know what we're dealing with. So Chris, you want to talk about that a little bit, that part of the process?
So part of the NYU endometriosis protocol is that after our first consult, we order an MRI of the pelvis, and this is helpful for diagnosing endometriosis, especially deep infiltrating endometriosis. It also helps us for surgical planning, just to make sure that we incorporate the right doctors with your surgery. So if we have a case where there's bowel involvement, ureteral involvement, that's a tube that transfers from the kidney to the bladder, or even bladder endometriosis, we can address that at this time of your surgery. So we'll incorporate either a urologist, a colorectal surgeon that's involved in the surgery as well, so that we can give you the optimal results from surgery. So it's really helpful for looking for things that are deep infiltrating. And one of the questions we had was about umbilical endometriosis, and this can definitely be seen on pelvic MRI, and we can see areas where this endometriosis grows. We can even find it in previous cesarean section incision sites and elsewhere as well.
Thanks. I think one of the things that we were talking about earlier in Matera's story was when she initially had her surgery, and all three of us here are minimally invasively. We were trained in a fellowship, which did minimally invasive surgery, meaning we did OBGYN residency, and then we spent additional time after that in order to do the fellowship. So it does happen a lot in that, more often than we like. Right? That when we hear the stories that patients going in for a laparoscopic procedure, expecting a laparoscopic procedure, and then ending up with a open procedure, and then staying in the hospital for 2-3 days. So that is really scary. And in reference to what Martera was talking about, as me as a patient, is that, I mean, I clearly do this for a living. And I just remember lying on the OR table, completely freaking out. Actually, I freaked out the night before. The night before, I had told my parents about my procedure. They had completely forgotten. I hope they don't watch this. And then, so everybody forgot. And I was like, how am I going to get home? Like, I need someone to sign me out of anesthesia. So I called my 24-year-old brother, just like hysterically crying. I was like bawling on the phone. The poor kid's like in Madison, and he's like, what's going on? Anyway, so I can understand that it is a scary, scary process, even for someone who does this for a living. And it just seems so irrational for me because I'm getting surgery at an institution where I know everyone. So I know, I mean, I handpick my team. I done that procedure, I don't know how many hundreds of times, and I was still really scared, especially when you're on the OR table as you're going to sleep. So it's definitely a really scary process. Okay, so I think there was a question from Matera. The question was, Matera, was there a point that Joy's question was there a transition point where you felt confident, or was there a turning point that confirmed your confidence in getting the surgery? So I think there are a lot of people here who are probably thinking about, hey, do I need surgery? Is that correct? I think that's what the reference of the question is. Do we need surgery or not?
Yeah, so yes, I think that knowing that when Dr. Wong, after I had my MRI done and it came back that I had stage 4 endometriosis, which is the worst case of endometriosis, and the amount of pain that I had been in, and also the desire to have children, and also with Dr. Wong just reinforcing to me that this is her area of expertise. Like, I didn't have to feel that that maybe something could go wrong, and not to take anything away from my previous surgeon, because she's also very amazing and I love her too. But this is what Dr. Wong, this is what she does. And just I had a couple of conversations with her, about 3. And like I said, when she said, this is what I do, you don't have to worry about anything. Like, this is my area of expertise. Then the way that I felt, as far as me being like really nervous and anxious about it, it subsided about that 3rd conversation. I'm like, you know what? She's super confident. There was nothing about our conversation that made her waver in her knowing that this is her job, this is her experience, this is things that she's done it a million times, and just showing that she cares. She's just like, I got you. You don't have to worry about anything. And so her having that much confidence is just like, well, why don't I have that confidence? Like, if she said she got me, she got me. So I don't need to worry about anything else. And that's
okay, so I'm going to ask Kelsey to comment on, like, how would you counsel patients when someone comes in with endometriosis? How do you counsel patients on, hey, do you need surgery? Do we do medical treatment first? You know, Matera referred to, also reference to PT. Obviously, we have a whole team of doctors and healthcare providers here that help our patient in a multidisciplinary patient-centered way, right? So the answer is not always surgery. It is certainly something that the 3 of us do here, or 1 is not always surgery, and 2, surgery is not the whole answer. It's just sometimes part of the answer. So Kelsey, you want to chime in?
Yeah, exactly. I mean, everyone kind of comes to us at different stages in their endometriosis journey. And a big part of our job, in addition to surgery, is really just making sure that we educate you about what really all the options are, both surgical and non-surgical, so that you can be really part of the decision-making process, so that you can find the solution in that moment that works best for you. I think Martera hit on some good points in kind of, you know, why we sometimes think that surgery is a better option. A lot of it's going to be based off of your goals. Some patients come to us having already tried some medical managements that have not worked well. Like Chris kind of mentioned, that's really where the imaging, especially the MRI, is super helpful. If we're seeing a patient who's kind of been on long-term medical management and they have, deep infiltrated disease, or in Martera's case, she obviously had quite large cysts, and that's a little bit, more clear cut that potentially surgery really can be the next best step. Surgery can sometimes aid in a diagnosis for patients who have had chronic pelvic pain, who again have trialed multiple medical managements and really haven't had good success with them. Maybe they're contemplating or considering different medical managements that potentially have more of a side effect profile. And so really getting a good diagnosis with the surgery is something that can be helpful in that case. And I think Martera mentioned as well, considerations about where you're at in your reproductive journey. If you, are thinking of having children, there unfortunately are areas where endometriosis can lead to some difficulties getting pregnant. And so part of where we come in to help is also to help in that instance, especially large cysts are something that we can help remove, which can help with fertility.
Thanks. There's another question saying, Martera, how did you notice something was wrong? I'm going to have Victoria answer this one. How did you notice something was wrong? How can we gauge if we're experiencing normal cramping from cramping that's signaling something else in the body needs support? So Victoria, do you want to comment on how do we gauge, how do we as practitioners, but also how do patients gauge, is pain ever normal?
So again, I think pain is extremely subjective. And so if you're having what you describe as severe pain, you should see a specialist for that. But what we do is, as Kelsey was saying, we can sometimes use OCPs or IUDs to try to treat pain, which would be the kind of medical management side of things. Or again, as Dr. Eswar was saying, we can order an MRI and look via imaging. Sometimes even on ultrasound, we can see if there's something going on with that. But again, just to reiterate, MRI is much more definitive to pick up deep infiltrating endometriosis. But again, it's all based off of your own experience. If you're experiencing what you believe to be severe pelvic pain, you should see someone for that.
Yeah, so our message from the very first webinar has been pain is not normal. So if you are experiencing pain, it is something you should check out. And I think there was also a previous comment about how one of your pain, when you presented to physicians, you did not feel validated. So the key is to find someone that you trust that will hear you. I think all of us on this panel, minus Chris, because Chris hopefully were not having menstrual cycles when he was younger. But when we were all kids, we've been told, like, I don't know how many times that pain is normal. Like I grew up with that. Like my mom told me periods are painful, and I just thought that was normal. And I have very painful periods and I thought it was normal, but that's not normal. So it could be that there isn't, let's say you don't need surgery. We're not saying surgery, you have pain, you need surgery. That's absolutely not what we're saying. We're saying that if you have pain, you should get it looked at. And if whoever you're seeing is not validating, hearing your pain, then perhaps you need to seek a second opinion. So that's what we're saying. And in terms of what are the signs and symptoms of endometriosis, I think Dr. Eswar can chime in on that one.
Sure. So I think for all women that have painful periods, they should definitely be evaluated. Endometriosis is seen in 1 in 10 women in the United States. And most patients see at least 5 to 6 doctors prior to being diagnosed with endometriosis. So it's something that's always on my radar when I'm seeing anybody for any condition, even if I'm seeing them for a annual exam. I'm asking them, do you have painful periods? And this is something that you'll see is that pain increases throughout your menstrual cycle, and typically is relieved at some point after your menstrual cycle for a period of time. If endometriosis progresses, patients typically will have chronic pain. So every single day they'll have pain, and it will not be resolved with their period. And that's just because the extent of the disease has gotten so bad that there's so much inflammation of the pelvis. There's upregulation of the nervous system that causes chronic pain conditions. So there's lots of things that we can see that initially patients will complain of when they're in their teens, that they get a painful period leading up to their period. After the period, their pain resolves for a period of time, and then it's very cyclical. But over time, if you continue to not treat that pain, it'll become chronic, and that's something that we see very, very often in our endometriosis center.
I think there's another comment here about if this is different from adenomyosis. Who wants to take that one? Kelsey?
Sure. I mean, so part of it is kind of the biology of it. So in general, endometriosis is a process where the endometrial glands, which really should only be growing on the inside lining of your uterus, it's what grows and sheds every month as a period, are actually growing outside the uterus. So kind of, it really can grow anywhere. We typically think of it in the pelvis, kind of in and around the uterus, fallopian tubes and ovaries. It can kind of sit on your bladder, sit on your rectum. So in addition to the symptoms Dr. Eswar was just mentioning, sometimes you can have pain with a full bladder or pain with bowel movements. So adenomyosis is similar. It's when that glandular tissue is actually invading into the muscular wall of the uterus. Either way, this tissue is basically in a place that it's not necessarily supposed to be. And in addition, it's responding to our natural fluctuations in hormones, the same way that our lining of our uterus grows and sheds every month. And that reaction can basically cause just a lot of inflammation. Obviously, we've been talking about in the case of endometriosis causing pain. In the case of adenomyosis, it can additionally be noted by painful periods. And some women have really heavy periods with adenomyosis as well.
Yeah, so I think with adenomyosis, the definitive treatment is actually hysterectomy, whereas that is, again, not the answer for endometriosis. I know there are a lot of social media and lots of celebrities who apparently had hysterectomy for endometriosis. So we want to make sure that you understand that definitely should not be the first line therapy and often will not help you, because by definition, endometriosis is outside the uterus. So taking out the uterus will not help you unless you also have adenomyosis. Unless the endometriosis has infiltrated into the wall of the uterus, doing a hysterectomy is not the answer. So we do want to provide you with all options. That if we have to get to hysterectomy, we will. Obviously, it's not a very difficult procedure, to be honest. Probably is a lot easier than a lot of the other stuff we do, but only if it's the right treatment for you. So we have to make sure that is the right treatment for you before we actually proceed with that very drastic surgical treatment. So Joy has another question. To all of the medical professionals, what component of your approach to treat this condition do you feel are missing from what seems to be common practice amongst other medical professionals who have not seen as much success? So I think one thing I'll just say again is the hysterectomy thing, right? I really do get very angry when I hear about all these unnecessary hysterectomies. But not just for endometriosis. I know this is our endo panel, but I often hear that about our patients who have fibroids who have only been offered hysterectomy, and that really gets me really upset. So I'll start with Dr. Eswar, and then we'll go to Dr. Castle. We want to know what components of your approach is it different from either what you experience in residency or what you see outside of our immediate group?
Sure. I think for us, obviously, we're a tertiary place, so people are sent to our endometriosis center that either have been diagnosed with endometriosis or at least chronic pelvic pain. One of the things that we do at NYU is we do use a multifactorial process, and with patients with endometriosis, about 40% of patients with chronic pelvic pain have endometriosis, but patients with endometriosis have multiple sources of pain, and about at least 30 to 60% of patients with endometriosis have another source of pain. So one of the things that we do at NYU is to evaluate and find these other sources of pain to help treat their other pain causes. So that could be interstitial cystitis or bladder pain syndrome. It could be IBS. It can be pelvic floor dysfunction. And a lot of patients that have had previous surgeries for endometriosis may have one of these other components. And they can have multiple surgeries, but if these other things aren't addressed, they will continue to have pain. And we also see patients that are continue to have pain over their lifetimes through something called central sensitization. That's when the central nervous system gets upregulated and other things that are maybe like background noise are interpreted as pain. So we can treat these other conditions, and we'll see that patients' pain gets improved drastically over time. So we'll address the endometriosis, we'll address the IBS or interstitial cystitis or pelvic floor dysfunction, and patients will see improvements in their quality of life. And that's one of the things that we have to look for pain patients, is that sometimes it's not so easy to look at how your pain is day to day. Even if after successful surgery, you may notice that your quality of life has changed. Maybe you are going out to do more things with your friends, you're going to family events, you're not missing school or work. These are things that we look at to kind of see if our surgery was successful and if your pain is being improved.
That's a really good point, right? I think women somehow just, one, have been taught to dissociate for pain, and two, just been taught to like continue through it. So one of the most common questions I get during like the pre-op visit when we're talking about surgery, immediately, when can I go back to work? And I usually say you need like 10 to 14 days off, but I'm working from home. Can I work from home? I'm like, well, I'm not going to follow you home, obviously. So if you insist on working from home, I cannot, but I work from home. I'm like, if I can be doing this at home, do you think it's any less stressful for me? Like if I'm doing a telemedicine visit with you, do you think it's actually, to be honest, it's harder. I'd rather be doing it in person. So maybe, yeah, I like don't have to do the transit time, but I was like, oftentimes I get more pissed off about email than, when I'm in the OR, I'm totally happy. Like, it's great to work with the team and have all this time be taking care of patients. That feels really joyous and rewarding to us. Whereas, when I'm answering really ridiculous emails and often get even more upset. But, the stresses in life, I think it just, women are just really good at placing themselves at a very low priority. We often prioritize almost everything else. And then our own wellness is at the bottom of the list and doesn't always get taken care of. But in terms of quality of life, I'm hoping that Victoria can comment on the EHP 30 questionnaire that we have started sending out to patients and how important that can be helping in terms of helping us track.
Yeah, so just a little bit of a quick background on my role with the Endometriosis Center. So I will be doing follow-ups for patients at 3 months post-op, 6 months, 9 months, and 12 months, and then, any time thereafter. But my goal is at each one of those appointments to go through, it's an EHP 30. It's a questionnaire, just basically gives us a better gauge of how your quality of life has been. Hopefully we can get a baseline one done before any sort of intervention. But at each appointment, my goal is to go through how your life has changed or since whatever intervention you have. So I don't know if I talked enough about that, but theoretically things should start to get better. As Martera mentioned, it takes a little bit of time for your body to fully heal. Surgery is, despite it being minimally invasive, it is still more or less an assault on your body. You have to give yourself the proper amount of time to recover. And I do agree with Dr. Wong, and I think we try to push our limits with getting back to work and getting back to normal life, but you really do need to give yourself the opportunity to heal fully. Martera, I feel like I talked to you at length about this. But, the hope is you give yourself hopefully that month to 2 months to 3 months of recovery time, and your quality of life makes a drastic change, So yeah, that's a little bit about the.
Yeah, the goal with the EHP 30 is even if you're not trending in the right direction, that way we can pick it up. I think sometimes it's hard to check day to day. Like you may not remember what yesterday, or if we're asking you to recall how you felt 3 months ago, it may not be very clear in your mind, and memory can be very distorting. The goal of tracking it is so that we have an objective way to measure, are you trending up or down? If you're trending in the wrong direction, is there anything we can intervene? Again, not surgery, but are there other levers that we can pull? Is it nutrition? Is it lifestyle? Is it whatever it may be? So we just want to make sure that after we take care of you with either surgery and or medication, we're not just releasing you into the world with no follow-up. So we want to make sure that we're still keeping track of you. If your symptoms start to return, are there other things that we can do that doesn't involve surgery that I think would be a lot more helpful? Because I think pelvic floor physical therapy may be helpful for some, may not be helpful for others. You know, all the coexisting conditions that Dr. Eswar was talking about, I think all of those things need to be addressed. So we just want to make sure that we keep close tab on your symptoms. And of course, you can see that Matera and Victoria have been talking about how women just disassociate from their pain and bodily, trauma. Surgery is trauma to your body as well. So we often store this type of stuff in a way that's maybe not the most beneficial. There's another question here. It says, what if endometriosis is being managed with an IUD and once removed, one successfully gets pregnant? Which is, again, totally awesome. We want you to get pregnant, assuming that's what you want. I'm assuming when you remove the IUD, you are trying to achieve pregnancy. What is the risk that endometriosis will continue to grow during the pregnancy and after? And if someone has endometriosis, how often should they be getting MRIs and check on growth? So I think, Kelsey, you want to take the first part of this question, which is, what is the risk that endo will continue to grow during pregnancy and after?
Yeah, I mean, this is going to be a little bit of an individualized kind of answer by patients and by history. I generally like to think if you've had good effects with the IUD, then, goal should be, just like Dr. Wang said, it's amazing if you can take the IUD out and get pregnant in a short span of time, just kind of limiting the time that you don't have the IUD in place. And then just kind of, speaking with your provider and making decisions about how you want to manage things postpartum. IUDs generally can be replaced pretty immediately postpartum. So if it's something that was working for you, it's something you can kind of go back on right away to just kind of, suppress and limit the growth of endometriosis.
And then there's a question about how often patients should get MRIs. So we're not suggesting you should get MRIs on a regular basis at all. That's why we check on the questionnaire to see how are you trending in the right direction. So we will only get imaging when you're symptomatic or getting worse, right? There's not a prophylactic, we're just going to keep getting imaging. I don't think that's actually helpful. So we would get MRI when your symptoms will start to worsen or something else is going on, something new is happening, but it's not a routine that we just start ordering MRIs every few months or something. That's really not what we do. And I think often I get this question, so I'm just going to put it out there. MRI has no radiation. So there's no harm in getting it. This is not a CAT scan. It will not increase your risk of getting any sort of cancer or malignancy, because is it lymphoma? I don't even know. It increases some sort of, is it lymphoma, guys? Okay, a whole panel of healthcare professionals, and we do not know what specific kind of cancer CAT scan actually increases. We need a radiologist. But there is increased risk of cancer with CAT scan or just abnormal amount of radiation, which MRI does not give you. Neither does ultrasound. So I hope to just clear that up. What else? So are there other questions? Chris, you want to take this one? Are there other conditions that mimic endometriosis? I guess
those are the ones I was discussing before. So yeah, the top 4 causes of chronic pelvic pain, I said again, was endometriosis, these other three conditions are seen very, very frequently. So interstitial or bladder pain syndrome. In patients with this condition, they'll urinate very, very frequently, over 20 to 30 times per day. They typically like to have their bladder empty because anytime the bladder is full, it irritates the bladder. And things that can elicit more pain is going to be spicy foods, caffeine, alcohol, anything that acidifies the urine. So that's something that we always look out for. In patients with pelvic floor dysfunction, patients will complain of painful intercourse, difficulty with starting their urinary stream, incomplete emptying of their bladder. And typically patients that have pain with intercourse, it's actually pain that lasts after intercourse. That can be for a couple hours to even a couple of days. And then IBS symptoms. So that could be constipative IBS or diarrhea or even mixed. So we try to look for all these things in our patients. Amongst all the, there's lots of other things that can mimic as well, but these are the top four. So we look at these first, and then every other patient's individualized to kind of see what other things that may pop up. Previous surgeries, things like that can also cause increased pain, as well as abdominal wall dysfunction, where it actually is their abdominal wall is spasm from previous workouts, things like that. Injuries can also mimic these symptoms of endometriosis.
So we didn't say this about Chris. He did a pelvic pain fellowship as well. So Dr. Eswar did his fellowship in chronic pelvic pain and minimally invasive GYN surgery. So he is also able to do some procedures that certainly I do not know how to do, including Botox injections and really evaluating for muscular dysfunction in the pelvic floor. So there are other things that this is why we're a team, right? We don't all do the exact same things, and we really complement each other in our practices so that we can give you the care that you need. So there are a couple more minutes left, but I do want to return to Martera for a second just to ask, what are the things that you wish you knew before you had the surgery? I don't know, I'm just putting it out there.
I guess the recovery time, I think talking about recovery time, and Victoria and we did have a conversation in length about me just taking the time that I need. And Dr. Wong, we had that conversation too. Like, take the time. You were like, take this time off. And I'm like, no, I got to get back to work. I got to get back to work. And it's true. It was something that you said that is in the chat. It is the disassociation from the pain. And I think that's what I had been doing. Like, I thought that, oh, I'm going to have the surgery. I'm going to be able to go right back to work. I'll be fine. And although I've been in a ton of pain, Victoria knows I've been emailing her every couple of weeks. I thought that I could just return back to work with no problems, no issues. I thought like, oh, after 2 weeks, I'll be able to go back to work, but really trying to separate my pain from every other responsibility that I had, and just knowing that it is okay to take some time for myself. It is okay to slow down. It is okay to be still. It is okay. Everything is going to work out. And just knowing with, I think Carol said the dream team, and has everyone else put, like, the group of all the medical professionals that we have on this call and not on this call just assured me that I'll be okay. I guess that's just some other feedback, but I feel like Dr. Wong, you answered everything that I needed or wanted to know, especially about the fertility stuff. We talked in length about the fertility stuff. I think the only thing that I did want to know, and sorry, this is like on the spot in front of everybody, I just wanted to see the pictures, what everything looked like.
Oh yeah. Is it not in your my chart? This is a constant problem with us. This is an IT issue that we need. Well, we're also working that fixing that workflow. But yes, we are intending. So this is, can I put this out there? We plan to, we're working on something that will allow us to send you a little clip to discuss what happened in surgery, ideally including pictures, but we do routinely take pictures. But we'll certainly can have this offline discussion about what sometimes the pictures, we don't know what happened to them. But I do think there are two things that you mentioned that are really important. Like, one, I think I'll just speak from my perspective, and this is, I don't mean to exclude Chris. So this is not about just women, but I think there's a huge part of me that feels like when I'm taking care of myself, that's selfish. So I always try to remember to take care of others first. Work, patients, friends, family, whatever. Everything else comes before me. And I do that a lot. I know Chris definitely does that with his family. We all do that, right? And I think there's a huge part of me. I mean, like right after my surgery, I was emailing, please don't do that because you're still under anesthesia and you're going to send out stupid things that you cannot take back. Okay. So I think my point is that, one, I think I felt selfish and that's why I didn't want to. And I'm going to project that onto a lot of you because I think a lot of us are feeling like when we take care of ourselves, it seems to be a selfish thing, but it isn't, right? Like if you're not 100% and you're pushing through it, then you can't really take care of other people as well. And this is something I recently started doing. Sorry guys, this is, I mean, this really spills into our lives. I started checking in with myself to see when I do things, is it something I really want to do or am I doing it out of guilt? Because I have to own that decision. I'm going to own it, right? I'm not going to say, I'm 42. I'm turning 42. I'm not going to be like, my mom was X to me when I was younger and this is how I turned out. That's like dumb, right? I'm an adult. I'm going to take ownership of my decisions. So if I go home on weekend to see my parents and they start criticizing me because that's only, I'm totally oversharing. This is the only way they know how to show love. I'm going to own the decision of going home, right? I'm going to own it. And when my dad is very anxious and when he triggers my anxiety, I have to say, you know, he has to own his part of the anxiety. He tries to put it on me, but I have to own my anxiety in reaction to that. I don't know if this addresses anything, but my whole point was just that you have to take care of you. And when you take care of you, everything else will fall in place. So don't, if you're going back to work because that's what you want to do, that's great. More power to you. But if you're going back to work because you're feeling guilty because something is not done and you need to do that, I guarantee you, you will be resentful. And that negative energy will not help you healing. So while this whole detour that I just took didn't necessarily relate to surgery, but I really do believe in, again, I've only started doing this 2 weeks ago, so don't think I'm a guru at checking in with myself because I'm very bad at this. My whole life has been checking in with externally, like, do I get the confirmation that I'm doing the right thing, right? Like, that's like all my life. That's how I got to where I am today. But I'm starting to learn to check in with myself and then owning that. So if you want to go back to work, because it is your passion, it is the number one thing you want to do, and nothing will stop you, then you should definitely go and do that. But if you're doing it for any other reason, because your boss is going to get mad, because whatever, this thing, if you don't get it done, no one will, you still have to own it, right? The decision, no one's holding a gun to your head, right? So you have to own that decision and then live with the consequences. So for me, I feel like if I don't feel like it's a whole body yes, and I'm like, I'm just going to go back to work because I can't do this, and then I start resenting other people, that's not okay because you made that decision. Nobody forced you to. So you have to stand up for yourself. If your boss is like, I need you to go back to work, and you're like, I'm 20% ready, 80% not ready, it's on you if you say yes, right? So I think a lot of it is us taking that responsibility to take care of ourselves. And when you don't want to say yes and you don't feel ready to say yes, being bold enough to say no. You don't always have to say yes, just say no. And know that when you are being good to you, it actually is a reflection on how you're going to be to everybody else. Okay, I'm going to stop because this is definitely my role is just taking care of your endometriosis. I'm definitely not the right person to talk about emotional well-being, but just some of my own personal journey that's been helpful for me. Okay, so we are gonna thank you so much. Definitely, number one, thanks to Matera. Thanks for everyone who had joined us. The next one, it's on fertility. So I know everybody wants to talk about fertility. So the next month we're going to talk about fertility, and thank you for joining this conversation, because Beining here, who is mute and silent, and she's the one who's helping us put together all of these things. And Beining will be, if you guys want to be part of our patient family advisory council, because we, again, want your voice in helping us figure out what is it that you need from us, right? So we really want you to be an active participating voice in this journey. And we're going to be there to support you in your journey. So if you want to be part of our PVAP, please let us know. Please let Beining know. I hope she'll be sending out a note to all of you. I'm sure we have all your contact information. So if you want to be part of this journey, we will be super grateful for that. All right. Thank you, everyone. Have a good night.
Good night.